Okay, I'll let them get the slides. Thank you so much for the kind introduction, Amani. Good morning, everyone, or good afternoon. Jesus, morning at home. I just texted my wife to say good. I just texted my wife to say good morning, so I'm confusing the times. This is actually my area of focus. So I'm very excited to be able to share a little bit about my perspectives on simulation training for pediatric emergency medicine. Happy to talk more. I know I've chatted with some of you about simulation-based research, but really sort of my thoughts are that there's a number of different applications for simulation, and one of those being simulation for training, the other using simulation to test and measure systems and conduct research. So this talk will be focused a bit more on simulation for training and simulation for medical education. So hopefully during this talk, we'll define some aspects of simulation and simulation-based training. We'll report 3 areas of focus within emergency care, particularly pediatric emergency care. We can apply simulation, and then describe some evidence-based practices. And if you enjoy this, you're welcome to join our workshop coming up, where we'll dive a little bit deeper into some of it. So excited to spend some time over simulation for the next hour and a half or so with these 2 groups. So one of the key things I want to highlight is that simulation is a technique, innovative and really neat to see a simulator and a mannequin that breathes, that blinks, that does many things that look like a robot. Many of those things actually do not enhance the education that we provide significantly. What does enhance that is actually this technique of simulation. So taking people through a experience, lived experience that you're guiding them through, and really being able to have that on demand. So in contrast to some of the clinical work where we don't know and it's unpredictable and we can't control that, we can control the content for our learners. It's immersive in nature. It replicates substantial aspects of the real world. It doesn't need to do that perfectly, but we can make an approximation of that. And really the beauty of this is the social aspect of learning, both the interaction during the simulation as well as the interaction during the debriefing. So simulation can look like a variety of different things. On the left of the slide here is simulation, some of our pediatric trauma and medical simulations. In the middle, some work that I've done using game-based learning to conduct screen-based simulations. And on the right side here are 2 examples of higher technology innovations. So one involving haptic simulation and virtual reality, the other involving more augmented reality, where you're actually seeing things progress and look at the mannequin that looks like a piece of plastic if you have the goggles off, but if you put the goggles on, even seeing chest movement, seeing a monitor and other resources. This concept of augmented reality is really a very exciting area for simulation, where I think we're going to be able to bring this to the masses, what I call democratized simulation, and not need a high cost piece of equipment in each center. So as I mentioned before, why simulate? I love to teach. I enjoy having bedside interactions with learners. I enjoy reflecting on my own experience as an adult learner and hopefully getting better over time. But unfortunately, those clinical experiences are few, unstructured, uncontrolled. Something like a stroke and having a diagnosis of Attas paralysis, like we heard in the last case, might be a rare event. You might not have opportunities to reflect. You might have another patient come in after. Or you might have opportunities to reflect, but have some moral and ethical dilemmas that the harm that occurred to that patient might negatively impact you, and really don't want errors to happen on patients. In contrast, in simulation, there's many experiences, so I can really provide you almost a limitless number of experiences. Our simulation training has shifted now from a assessment standpoint and I'll talk about this more in the workshop, but more to what we call a mastery learning approach, where we actually have shifted from time-based training, where we say, I'm going to have someone come to the session for an hour, but saying, I'm going to have someone come to the session until they are proficient and hit a mastery standard. The experiences can be quite structured, quite controlled. The feedback can be quite frequent. There's a variety of different debriefing frameworks. Some reflect in real time, what we call reflection in action. Some are reflecting after. Some are actually even reflecting down the road with what we call a delayed debrief. And then really here, errors are, I call them a high five moment. If I go through a simulation with you and you've done perfectly, it's wasted both of our time. So hopefully we can have some errors happen, have some opportunities for improvement. One of the key elements of simulation that I think is really important with the change in the US, I'm not sure if you see the same here in Saudi, is with the change in clinical exposure of our trainees. So in the US, if we look at on the y-axis here is hours of practice, and on the x-axis is the trainee experience. So in the model when I trained, really when we are at a unlimited number of work hours and not having as many advanced practice providers or physician extenders, we were really getting to that 10,000 hours of experience in pediatric emergency medicine by the time we were done with residency, beginning fellowship. That changed and sort of progressed to happening at the end of fellowship. And now I would say for many of our US trainees, and perhaps those here in Saudi as well, that has progressed to really being something that doesn't occur until we are at the attending level. So, you know, I think this gets at the fact that the uncontrolled nature of clinical experience makes it challenging. From a simulation-based training evidence standpoint, and I know I wasn't going to talk too much about simulation-based research here, but I think there's very compelling evidence and really a highlight. I've been doing simulation-based work for about 15 years now, but I think a highlight for our field was back in 2011 when we had our first major paper in JAMA. And this was a technology-enhanced simulation for health professionals, systematic review and meta-analysis. David Cook, who's the lead author of this, has published a series of medical education meta-analysis that are quite powerful. But this meta-analysis really looked at the breadth of simulation-based research and demonstrated that simulation led to large effects for provider outcomes. So if we look at the hierarchy of evidence, it did have people improving their knowledge, their skills, their behaviors, their clinical performance, but didn't show a substantive effect on patient outcomes. And over time, I think we've seen since 2011 more of this research that's demonstrated effects on patient outcomes, which I'll come back to later. I will say that you know, the simulation-based research area now is at a point where we need to shift from if simulation works, that dichotomous yes/no, to why it works, how it works, whom it works for. So, you know, in my trauma case, I talked about this this bicyclist that was struck and had a hyperacute injury requiring resuscitation for blunt abdominal and head injury. And really, how can simulation improve outcomes for this patient? So we have a patient that's going to have an outcome, and we can look at this across the Dunabadian framework that we heard before about from my colleague, Dr. Shah, and really looking at the structure of care as we're going to focus today. We can also do work looking at processes of care by trying to redesign systems, but simulation for training is really in that structure of care. So getting a group of people together to function as a team, to train together, to work towards improvement. So what to simulate within this area? I think the strongest evidence relates to three elements. So probably the strongest simulation-based research has occurred through both the military, aviation, as well as now medicine. It's interesting, I have some colleagues in aviation simulation, and about 5 years ago, they mentioned that actually aviation, we always quote them, we always talk about them, say simulation was born and has its bearings in aviation, and we've actually surpassed them. They've actually now started to adapt some of our simulation-based techniques and theory within aviation. I still say that I've been to the Houston NASA Simulation Training Center, and I would say that they still have us quite beat, but they lock their trainees in the same center for over 30 days straight. If we could do that with our residents and trainees, we might have as good of an outcome with our simulation. So teamwork and communication, procedural skills, and clinical decision making. We spoke about the pit crew mentality. We saw at the beginning of this conference that group of individuals that were changing the tire while the car was moving, and repetitive practice, but also teamwork and communication are necessary to do that. So what is a team? Whether it's that team changing the tires or your team in the ED or your team on the football field, a group of 2 or more people working together with a common goal. And I think one of the things that I really like to highlight is the interdependency there. Many times people are conducting simulations and the focus is really on the team leader. And I think this interprofessional and sort of hierarchical approach to simulation involving interns, residents, fellows, attendings should go beyond just that leader and focus on the other members of the team and take opportunities to improve everyone's skill. So we've conducted a series of projects looking at the impact of simulation on trauma team training in our department. We've subsequently looked at, unfortunately, I sent a new version of these slides and they're not updated, but we subsequently looked at the impact of this on patient outcomes and have actually demonstrated improvements in processes of care. And then most recently, Aaron Jensen, a mentee of mine, was able to demonstrate, looking at some ACS, American College of Surgeons trauma data, that centers that had more active simulation actually had improvements in survival rates. So from teamwork and communication, there are some constructs that we teach. If you have not seen the team steps curriculum or not familiar with that, I would really implore you, even if you're not interested in simulation, to look at AHRQ team steps. This is a set of communication rubrics that's available for free through our Association for Healthcare Research and Quality, is really grounded in work by NASA as well as the aviation industry and some best practices that are quite commonplace in our departments. So things that prevent medical errors, like using closed loop communication, things like sharing your mental model or thinking aloud, and really setting a standard set of expectations for our team members. The effect of simulation, I think that I would say most stands out in terms of why simulation works from both a theoretical as well as an evidence framework, is really the application of adult learning theory and debriefing. So debriefing is a facilitated reflective discussion after an experience. It involves actually a bidirectional discussion with learners. So it's not that unidirectional feedback where I'm just going to tell you, you should improve this, you should improve that, but works towards improving concepts and actually having a dialogue and a discussion that is much better about embedding learning. And even looking at things like fMRI and other studies, this is grounded in a strong theory and evidence. So the Kolb's learning cycle is really a tried and true adult learning theory. This was developed by Kolb and adapted from really all of the psychologists that we learned about in undergrad, Dewey, Lewin, Piaget. This cycle really breaks down learning into the cyclic approach where you have an opportunity to have a concrete experience, be it a simulation or a real patient clinical experience. You have the opportunity to sit down, reflect, and discuss that experience and what we call deepen your understanding of what the events were, what went well, what could go better. Very importantly, then you need some time to conceptualize. So you need some time to reflect and think. I think one of the struggles that I have, I'm fortunate to be one of the editors for a major simulation journal. So two pet peeves that I have with the articles that we receive is many are just saying we did a simulation, people liked it, which we're beyond that based on 2011 evidence now, so now over a decade old. The other piece that I think is really problematic is the one and done simulation, that this idea of we did one case and someone learned something after that, or even we did one case and it was innovative, I think is no longer the state of the art. We need to start looking at this over time and how that impacts people. So after that simulation and debriefing, and the deepening through abstract conceptualization and further learning, potentially reading more, having a repetitive experience. And because again, the repetitive experience is unpredictable in the clinical setting, as a fellow or even as an attendee or a medical student, you might see that bicycle struck today. You might not see that case again for ever. You might not see it for a year. You might not see it for a month. So the benefit of simulation is that it allows you to have that in a controlled setting and as well as a controlled cadence. And it also can be augmented and must be augmented by other curricular activities. So another key concept here is what we call curricular integration. Debriefing is a talk in and of itself. I'm going to have a talk in the next hour for an hour. I would say that many of us have worked in this for a year or 2 years doing some fellowships. We have Dr. Mani up here who's done that. But I really want to highlight a tool, and this is a tool that was created by a friend and colleague, Adam Chang, who's really the thought leader in debriefing nationally and internationally. And really there's 4 elements of debriefing. So this slide does not go into some of the full arc or what I would call the 3-act play of simulation. So we have a pre-briefing where you're setting the stage, having people understand what the expectations are, sort of laying out what that activity is going to be, whether it's a single case or a course, showing them that this is a safe place ideally, then moving on to the simulation and then the debriefing. So in the debriefing, that is also a Kolb's experience where you're allowing people to reflect, to describe the experience, to analyze that, and hopefully apply and summarize. And this is a really nice off-the-shelf, if you go to Pearl's debrieftolearn.com. This resource is available, but there's sample phrases, and what I want to highlight is this is actually available fully in Arabic, so a nice resource. There's a compendium. I know I said I wouldn't talk about it, but it is an area that I'm very passionate about, of simulation for research or system improvement. And I don't know if the systems-based simulation tool is translated into Arabic, so maybe it's an opportunity for someone to work on. Yeah. And then some of the pearls are translated into Arabic as well. My initial foray into simulation and pediatric simulation actually was quite different. So we heard a talk about airway before. So one of my initial interests, and we heard about lumbar puncture, was procedural simulation, so psychomotor skills. I still think this is an important modality for teaching those skills. And I think there's some different constructs from an educational standpoint that I would provide. But I would say that these constructs and these educational activities are probably more based on a longer body of evidence. I think people have been training since back, we went to see the fortress here and heard about military training, but since all the way back thousands of years ago, procedural simulation has been going on for a long, long time. But a procedural skill is a mental or motor activity required to execute a manual task. Many times this can be going on during a team-based simulation. Our work really tries to scaffold, so we layer the technical skills. When someone has those technical skills and has practiced, we would allow them to then perform those skills during an interprofessional simulation. So some independent learning followed by some group learning. Our group has tried to layer really thousands of years of evidence into a theoretical framework for skills-based training best practices. So this work by Taylor Sawyer, who's a neonatologist, and myself and a variety of others, really tried to put together this concept of psychomotor or procedural learning, coming from, again, even things like music, how people learn a procedural task. The first phase is the cognitive phase, and this is pre-learning. It's really critical to have someone show up to a suture workshop like you did yesterday. They've never seen a laceration before. They've never seen a Kelly. They've never seen a suture. That's not the appropriate place to start that journey. So hopefully some videos, pre-learnings, understanding what the steps are, what best practices are, and really the construct that we describe is the first phase is learn and see. So we know that see one, do one, teach one has moved on to see one, sim many, and then maybe teach some. But really here, moving on to observing that expert in the clinical space. And then after that occurs, and once someone is really understanding the procedure, then you move on and to this practice, prove, do, and then finally we'll get to maintain. So what we call the LSPPDM framework, which the Canadians did a really lovely podcast on this work. And the one problem they had with us was that we had a really not so great mnemonic. So if anyone has a way that you could have LSPPDM sound really nice, that will help our work and help to broaden this. But the psychomotor phase gets at what I was mentioning in terms of mastery learning and deliberate practice. If you have read or have heard of Malcolm Gladwell, he's famous for some of the 10,000 hours work. His work is really grounded in a large body of evidence by a giant of the field named Anders Ericsson. So Anders Ericsson and Malcolm have actually chatted about this, and the 10,000 hours was a way of sort of making this accessible to the lay public. And even Malcolm Gladwell would say 10,000 hours of crummy practice, you're still going to be a crummy violinist. And some people, 10,000 hours is not necessary. So that's a little bit different for everyone, was averaged over time. But I would say in medicine, just as in some of these other areas, this concept of simulation for learning, what we call formative simulation, where you're going through, you're practicing, you're getting coached, is vital. And I think we've understood that for a long time, but shifting to what we call a mastery learning model, where there's a minimum passing standard, is a real frame shift in medical education. So this is not saying you're an intern, you've now a second year, you can do this independently. It's saying you're an intern, well, maybe you can intubate as an intern if you can demonstrate mastery in intern year. Maybe you can't intubate as an attending if you haven't demonstrated mastery yet. There are some residencies, particularly within orthopedic surgery, that are trying to take this approach throughout residency and for promotion and layering this over things like entrustable professional activities. But the next phase would be summative assessment. So this is where you're proving that you can do something. So now that simulation is your test. And when you pass that test, then you're ready to go on and perform on a patient. But really before that, I would say that this is a little bit different for the different procedures. So for something like lumbar puncture, one of the classic examples that I give, and this was an area that I focused a lot of my early work on, is that with the appropriate supervisor, and a nurse said this to me once, she said, don't worry, that doctor, they don't really know what they're doing, but just tell them to hold the needle and I'll push the baby onto it. And that actually works, for that procedure. It's not going to work for intubation. So I think that, performance on patient can happen at different times. And I would slightly change this model to say that, it's a graduated level of what we call entrustment, and this whole field of entrustable professional activities is coming up. Now that I'm getting a little older and working less, one of the struggles that I have personally in reflecting is skill deterioration. So worrying about maintaining my skills and thinking through whether or not I am still proficient to do some of the things that my fellows are doing, particularly things like ultrasound. So remediation may be necessary and repetitive training is necessary. We know I'm lucky to serve with the American Heart Association on their education guidelines committee. And I think it's this balance. I know you're taking PALS and doing some of these life support courses here. It's not like AHA doesn't know that every 2 years is not the way to do this, but how do you come up with a model that allows people to train? Likely every 1 to 2 months is what's needed for some of these skills. And we're working on it. There are some distributed models in the US that are happening now. I don't know if anyone in the kingdom has moved towards any of these models, but there's carts that are on your unit that you sort of can train repetitively every 2 to 3 months and not need to go take a full day class. So, I know that American football is something that probably hasn't permeated as much over here, but I think my highlight for this last piece here that I want to just remind you of is that it's not about practice. It's not about how long you practice. It's about how well you practice. So deliberate practice should be hard. Frankly, it should be a little painful and stressful and uncomfortable. And just like practicing for a sport or going out for a run, if you are running at a very slow pace, you're probably not going to improve your times. If you're running at a nice pace and having a program for your schedule and training, that will help. So, moving to sort of where we want learners to end up, I just want to highlight that our goal within our department is not to get our trainees to expertise. And I think this is actually another challenge and struggle that I have within medicine, that really when we try to apply some of these procedural training adages, I don't want everyone to be a concert pianist or violinist. I want them to not frankly break the violin or have really bad notes or give me a headache, if I use the music analogy. So I want them to be competent. And I think within this paradigm, what I like to mention is that the most dangerous space for this individual to be, or these trainees to be, is in what I would call the unconscious incompetence, which we, my updated slides have this layered out, but this guided response is okay. If you don't know, you come grab me. I'm okay with that. But when you go in and you do something that perhaps you are unconsciously incompetent, you don't realize how much you don't know this procedure. Maybe you've seen someone else do this once. That's quite dangerous. So actually a frame shift that I aim for in our residents is move them to conscious competence in certain procedures like intubation, and then hopefully conscious incompetence, and then hopefully get them consciously competent by the time they're a fellow, and really to become an expert where you're actually practicing what we call heuristics or taking some shortcuts or able to manage those difficult cases. You can't do that for everything as an attending. So I feel like I have some of those skills for ultrasound. For intubation. I do not have those skills for ultrasound. And I think you need to know what you know and what you don't know. Getting back to repetitive practice and trauma, this gets at some important skills-based training, as well as even overall education work that demonstrates that we not only need to think about learning curves, which are on the left side here, but actually forgetting curves, that we actually all have our own curves, and each procedure has this for how quickly and how often we forget things. So recognizing that if someone is only trained to competence, likely by the time that patient comes in again, they're going to actually be not competent or not proficient. So just having some repetition is not adequate in between, because if you train them back up in between, they're still going to fall below. So really what we want to do is overtrain or overlearn. I don't know if anyone has done any of the language duo apps. Some of these are very good at this, where it actually learns when you're forgetting the words of a new language that you're learning and starts to hit you more frequently with those words, and it's what we call adaptive learning. So where to conduct research simulation, and specifically resuscitation simulation. I don't know if you're doing any in situ simulation here, but I want to highlight that simulation for learning and simulation for improvement can be blended together by doing it in the workspace. It's something that I'm very passionate about. I think that a pillow or a doll in your workspace is actually probably better than my $150,000 simulator in the Sim Center. So I am a big proponent, particularly for our fellows, of doing this in situ. For my medical students that are very early on, doing it in the Sim Center, I think is reasonable. Lots of benefits of in situ. You get the real world teams, real equipment. You get really, I think, a much more robust experience. Getting back to the learner outcomes and looking at some of the evidence. So this is a summary of some of the evidence in trauma simulation. There's similar work that we've done in procedural training as well as resuscitation training, but climbing this pyramid, there's a variety of educational pyramids, but I would just encourage you to start considering, if you're looking at any simulation-based research or conducting these projects, moving from the bottom of this pyramid of this is a fun experience to procedural or process outcomes, getting back to that Donabadian framework. So things like intubation success rates, CT scan success rates, and then hopefully moving from that all the way up to what I call the holy grail of patient outcomes. So we have seen that in trauma and cardiac arrest. We've seen that as well. There's a couple cardiac arrest studies that have showed demonstrated improvements in outcomes. Unfortunately, these are still at the association level. So if we mirror some of the research that we've heard about in the clinical setting, we have more of a need for randomized clinical trials. We haven't gotten there yet. So simulation to improve systems. I did want to highlight from my earlier talk, I talked about having tags up in our room with stickers. This is something that came out of our trauma simulation. So these system-based simulations allow you to identify issues, mitigate those issues, but also train people up. So our trauma simulations are the way that we get them to actually start using these stickers. This is the example of the Pearls framework for systems improvement. So a slightly different way of debriefing. It not only includes, how did that go, but actually what factors within our system were barriers or facilitators, what safety threats are here, what can we do to make your work easy and make it more likely that the system will support you. So some take-home points here through this whirlwind talk is debriefing is by far the most impactful part of simulation-based learning. If done well, there's some great scripts out there. So while you can take a course, there's some off-the-shelf ways of doing this. I'm happy to share through COVID, and unfortunately, these are the older slides, but through COVID, there's 3 or 4 different free open access medical education simulation-based resources that really have come out to fruition using things like Google Slides and YouTube so that you can conduct simulation in a low or no cost way, and really with this goal of democratizing simulation. Mastery learning and evidence-based practices for procedural simulation are needed. And then again, I give you a little teaser here that simulation is evidence-based to improve care through training. If you want to talk further, I'm happy to talk about simulation as an evidence-based approach to improving systems. We've markedly demonstrated, whether you're building a new hospital or trying to improve your own environment, that simulation can be a very effective technique. We heard before about the Viper study, and the Viper study using video-based resuscitation actually came from a number of my colleagues that were recognizing the power of looking at video in simulated cases and then saying, wow, what if we could get the same video in real patient cases and use that to understand processes of care and where we want to improve. So thank you so much, and appreciate the opportunity to share with you, and happy to take some questions and share a little bit more on debriefing if anyone wants to join us for that after.